The Knowledgeable Provider podcast is intended primarily to entertain, also to inform, but it is not a substitute for actual medical training and should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, please make an appointment to see your own knowledgeable medical provider. The opinions expressed by me and anyone else who happens to appear on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than the lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. Look, this is all for fun, okay? Don't sue me. All right, on with the show. Hey there, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. Before we get started here, I do want to throw out a plug for the Knowledgeable Provider Patreon page. You know, in my little anniversary episode, I said that I was going to shut that down because nobody had ever interacted with it. And then you know what happened? Someone did. Someone signed up. Someone's paying me. And I appreciate it greatly. That really adds a whole new level of motivation to keep doing this and feeling like somebody's getting something out of this. I really, really appreciate that. To my one Patreon supporter, thank you so much. It's only $5 a month in addition to my gratitude and providing me with some motivation and affirmation. It also helps offset the cost of doing this, which is not like a whole lot of money, but it does take a whole lot of time and the equipment to do it and the cost of maintaining a website, all the different software that you have to buy licenses for and whatnot. It does add up after a while. And then, of course, I could be using all this time to like work somewhere and make money. So it's much appreciated, not required, but appreciated. If you want to throw some money my way in exchange for the content you get here on Knowledgeable Provider Podcast, just head over to patreon.com/knowledgeableprovider. As a special thank you to anyone who signs up, you'll get access to the private Knowledgeable Provider Discord server. If you're not familiar with Discord, it's essentially a chat room. I've got divided up into multiple channels for different topics of discussion, episode ideas, general clinical topics, an area for stories if you want to share anything on the critical incident segment. I've also invited everyone who's been a guest on the podcast, so we have a handful of folks in there now, and I hope that will build up into a nice group of interesting people who enjoy talking about medical things. I've been just keeping it pulled up on my desktop at work and dropping in throughout the day to share my thoughts of whatever's going on at the office or whatever's going on in the news, that sort of thing. I appreciate everybody who's already participating in that, and I hope you'll consider joining us as well. And of course, if a bunch of people sign up for the Patreon, I would definitely consider doing some bonus content or meetups or merch, all the things that podcasts do to reward their financial backers. So I definitely see some opportunity for growth there in the future. But yeah, if you're interested, go sign up. I'd really appreciate it. For today's episode, I want to start a series that I'm calling the Nutshell series, as in trying to cover complicated subjects in a nutshell. One thing I haven't really done on this podcast yet is just talk about the meat and potatoes of primary care, the preventative medicine, the things that we're all working on all the time. You know, we get pulled into talking about so many things in primary care, and it seems like a lot of times it ends up just being the flavor of the month, right? Whatever freaking medications are being advertised or whatever medical issues are popular. Of course, right now it's trying to find ways to get everybody on GLP-1 agonists or talk them out of being on GLP-1 agonists, depending on the situation. And I think we tend to get lost in all that stuff sometimes. But at the end of the day, I see our main role in primary care as trying to keep people healthy in the long run, trying to keep them from having heart attacks and strokes or suffering major complications of diabetes or prevent them from getting cancer or pick up on the cancer before it becomes a huge deal. Of all the stuff we end up trying to deal with, I would say those really are the core values and the core mission of primary care providers. And I've never really talked about any of that. So I'm going to try doing some of these nutshell episodes. I'm going to start with hypertension, diabetes, and hyperlipidemia, and then maybe we'll move on to some other topics. But I'm going to start with hypertension. My goal here is just to create a sort of brief synopsis of how I manage hypertension just from day to day. Think of this as like you're doing a clinical rotation with me and we're talking about it in the hall before we go into a patient room, or maybe even how I would talk about it with a patient. I think probably the biggest challenge that really any healthcare person faces is trying to take all the knowledge and all the complicated data and hundreds of pages of guidelines and blah, 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 and just condense it down into like, here's a one sentence summary of what I think and what we're going to do. And that really is challenging. I can only speak for myself, but the way my brain works, I need to just boil everything down for myself in order to understand it as well. I know there are super smart people out there who can read these studies and absorb them and then regurgitate them back to the patients. Well, the Resolve trial showed that 14% of the number needed to treat is blah, blah, blah. And that's great if your brain works that way, if you're that smart, but that's not me. The whole left brain, right brain thing, I'm the side that's more verbal, more oriented toward language and art and that sort of thing, as opposed to the side that's more oriented toward math and numbers and all that. And I am of limited intelligence in the first place. So what I need for myself is just to boil everything down and make it something simple that I can remember, that I can go by. So that's how I feel when I'm reading these big research studies and guidelines. Like, let's just condense it down. Most of these articles already have the whole article, and then up at the top you have the abstract, which is just sort of the quick and dirty version. I'd like a section above that for the really dumb people like myself, where it just has, thumbs up or thumbs down, or like green, yellow, red would be nice. Because essentially that's what I'm going to boil it down to in my head anyway. Medicine equals good, or medicine equals not good, or screening equals good, or whatever it is. That's what I need to remember and actually incorporate it into my day-to-day practice. And that's how I need to explain it to patients too. The area where I live and work, there are a lot of engineers. You can't throw a rock around here without hitting an engineer, because our whole area is based on defense contractors and space and science and things. And a lot of them probably would respond better to the numerical data side of things. And if I'm dealing with somebody like that, sometimes I will actually just pull up the studies and go through the data with them and show them the numbers, because I feel like maybe that speaks to them more than my little simple, oh, this is good, you should do this. And with hypertension, it seems like it should be pretty simple, right? You want the blood pressure to be below a certain level, and if it's not, then you do something about it. Like everything else in medicine, it's not that simple. If you actually look at the hypertension guidelines and all the literature about hypertension, of course, it's just dense and it goes on and on and on and on and on. So how do we translate that into just dealing with patients? Well, here's how I have it all stored in my brain. This is certainly not intended to be a thorough review of guidelines or a comprehensive lecture on how you practice hypertension management. Obviously, you do have to read all that stuff. You have to know all the data. You have to figure it out for yourself and put it in your own brain in a way that you can handle it. But here's how I think about it. There are a bunch of different guidelines, and they're not all the same. And that's really the first thing to talk about. In order to treat hypertension, we have to define hypertension. And so there are all these definitions from all these different societies and organizations, and they don't all agree on the definition of hypertension. It was kind of a big deal in 2017 when the American College of Cardiology and American Heart Association dropped the definition of hypertension to anything above 130/80. A lot of the other guidelines still put it at like 140/90. So how do you figure out who actually has hypertension? As far as the numbers, I typically just try to stay in that range. I would say most people probably run in that 130/80, 140/90 kind of range. And depending on the patient, I'm usually good with that. People's blood pressure tends to rise as they get older. Cardiovascular system becomes less compliant, and so the pressure is going to go up. So if you expect your 90-year-old people to have 120/80 blood pressure, it's going to be hard to achieve that. And it just makes sense to me that you can allow a little bit higher blood pressure as time goes on. So all of this really depends on the patient in front of you. I don't think most of us are going to be in too much of a hurry to put an 18-year-old on blood pressure medicine. And I don't think most of us are going to be too aggressive with a 90-year-old trying to get their blood pressure down to where it looks perfect. But for the people in the middle, the adults in their 30s and 40s, and the middle-aged folks in their 50s, 60s, I would love to see everybody at 120/80, 110/70. And you do see that with the people who are treated aggressively, or the people who are super athletic and take really good care of themselves, or those handful of people who are just extremely lucky and have good genetics and have never had high blood pressure despite never doing anything to really work on that. But the people who float around 130/90, I usually just let them float. I encourage them to check their blood pressure at home. Let me know if it's higher. Then you run into the situation of the person who comes in and their blood pressure is always high in the office, but they swear up and down that they check it at home and it's fantastic, 110/70. And I believe the people who bring in the written logs with their blood pressure checked every day or twice a day or 3 times a day, who can show me months of data that is true. A lot of times I really don't so much believe the people that say, oh, it's fine when I check it at home. I think probably what that means is they checked it once at home under ideal circumstances and it was fine, and so they just assume that it's fine. Or you have the people who will go, well, I feel fine, I'm not getting headaches or anything, so I'm sure it's fine. I don't really try too hard to talk people out of that for the most part. It's your body, right? It's your kidneys, it's your heart. If you tell me you have great blood pressure when you're not here, I believe it. If you want to believe that, fine with me. The people who've done their research and know that it's bad to be on medicine, fine. I'm not going to spend my life arguing with those people. And the other thing you have to look at with an individual patient, of course, is their overall cardiovascular risk. If you have a 20-year-old who's in great shape and comes in with a blood pressure of 140/90, certainly not as worried about that person as somebody in their 50s who has uncontrolled blood glucose and high cholesterol and a family history of heart disease and who smokes. Those are very different patients, right? If you have somebody with high cardiovascular risk, obviously you need to be more aggressive with trying to get their blood pressure down. And that's probably my strongest justification for when I decide to really push blood pressure medicine is I say, look, you have all these risk factors, you're a smoker, you have diabetes. Most people will bring up themselves, oh yeah, everybody in my family tends to die at 50 with a heart attack. And those people tend to be more amenable to trying treatment. So that's step one, identify the patient that we're going to try to push this with. Step two, what are we going to do to try to lower the blood pressure? Of course, we want to encourage lifestyle changes, right? And some people will do the classic, well, give me 6 months to work on it. We'll see how it is in 6 months. So what do we tell them to do to work on it? You want to exercise regularly. You want to try to watch your sodium intake. And that's a really hard thing to do. I think some people think that that means you don't pick up the salt shaker and put salt on your food, when really the sodium that you have to watch for is the sodium that's present in processed food. And by processed, I mean like anything that's ever been touched. I tell people if it didn't come directly off a plant and into your mouth, it probably has a lot of sodium in it if it's been processed or dealt with at all. So you have to read the labels, and it is really hard to stay away from eating a lot of sodium, at least in the United States. That's a real challenge for people. As far as diet recommendations, I tend to just recommend either the Mediterranean diet or the DASH diet. And that's probably a whole other episode, and you can get as detailed as you want with all the dietary stuff. But really what it comes down to, of course, is more fruits and vegetables, more lean meats, less of everything else. Weight loss, a lot of times you do see people's blood pressure trend up and down along with their weight, but not always, right? You can't just look at a person and tell, oh, you have high blood pressure or you don't. You have skinny people that have really hard to control blood pressure, and you have very large people whose blood pressure is perfect all the time. So you can't always tell by looking. So we've identified the person who has hypertension. We've gone through lifestyle modification things. Now we've made it to the point that we want to talk medicine. And that may mean in the same visit, we've made it to the point where we want to talk medicine, or it may mean that it's been 3 years and we've been messing around with this and now we're ready to talk medicine. It really just depends on the person in front of you and how they feel about things. Some people just are not going to take medicine. You can forget it. Some people are all about it. If you suggest something, oh yeah, absolutely. Put me on medicine. So you have to feel that out. But once we get there, how do we figure out which medicines to use? Pretty much your options for first-line treatments are ACE inhibitors or ARBs, so that's the prils and the sartans, calcium channel blockers, that's the dihydropyridine type of calcium channel blockers, so like amlodipine or felodipine, and thiazide diuretics. My general approach is to start with an ARB. I feel like they're a little bit cleaner, not as many side effects or issues with the ACE inhibitors. Of course, with those, you have to worry about, the big one is the angioedema. Also, you can get a chronic cough with those, much less chance of that happening with the angiotensin receptor blockers. So I used to start with losartan all the time. More recently, I find myself changing a lot of people to olmesartan just because it works better. So now I'm pretty much just starting with olmesartan. I don't like to wallop people right off the bat. You know, I'm not going to put them on the highest dose of one right off the bat typically, but I would like to put them on enough that it works. So if we're talking about kind of your typical middle-aged person who needs blood pressure medicine, I don't really like to start with the 5 milligram dose of olmesartan. I usually will go with at least the 10 or 20, and then you can move up to 40. If you're adding a second medication, I usually go with the thiazide diuretic, so that's going to be hydrochlorothiazide or chlorthalidone. Of course, the big issue you have to worry about there is potassium. Those are both potassium-wasting diuretics. The HCTZ is much shorter acting than the chlorthalidone. Actually, I had a couple patients end up in the hospital because of getting on chlorthalidone and just getting super dehydrated or have their potassium get whacked out. That's a pretty powerful diuretic, actually. So usually I'm going to go with hydrochlorothiazide first. I don't think most people tend to notice that diuresis with hydrochlorothiazide like you would with Lasix. I think it's more of a gentle sort of diuresis, but occasionally we'll have people say, oh yeah, I have to run to the bathroom every 10 minutes after I take it or whatever. And if we have to add a third, typically I'm going to do amlodipine. The big thing with amlodipine, which is a calcium channel blocker, is that it causes swelling in the feet and ankles because of the mechanism, right? Because it dilates blood vessels, so it can potentially cause swelling. And I would say that's almost the rule rather than the exception with amlodipine. Some people don't swell with it, but really a lot of people do. And that's also something that we can kind of overlook, right? A patient comes in complaining of swelling, and we're like, oh, we need to do this diuresis and, get you on compression stockings and check your veins and blah, blah, blah. And we don't remember that there's amlodipine on their list. A lot of times you can fix somebody's swelling if they're complaining of that by either cutting back or stopping their amlodipine. But anyway, that's normally my third line agent that I go to. In general, it's better if you can do combination pills, right? Just to reduce the number of pills that people have to take. And all these different blood pressure medicines are made in all these different combinations, either double or triple combinations. So you can always look for that. Probably a little more chance of pushback from insurance companies because they're going to be more likely to cover the single ones. But really, all these medicines that we've talked about so far are old, cheap, generic medicines. So really, cost should not be an issue. If we're on 3 and we're still having blood pressure issues, now it's time to start reaching for some less common things. I like to go to spironolactone, just a mineralocorticoid receptor antagonist, or MRA, that acts as a diuretic. Of course, it's a potassium sparing diuretic. So in that situation, you have to worry about the potassium not being too low, but too high. If they're already on thiazide, then in my mind, that sort of helps balance things out as far as looking at the potassium. Other less common things to reach for would be beta blockers. Beta blockers in general really have more effect on the heart rate than they do on the blood pressure. But if I reach for a beta blocker, it's usually metoprolol. With those, in addition to the blood pressure, of course, you have to worry about knocking the heart rate down. I'm usually less willing to go with the beta blocker if the patient already has a resting heart rate in the 50s or 40s because I don't want to slow that down too much. Other things you can reach for, clonidine, I think used to be more popular. I know a lot of the older patients will have been on clonidine for a long time, and they still have that mindset of if I take my blood pressure and it's over a certain level, I have to take a clonidine and bring it down really quick. And the thinking on that definitely has changed. We know that it's not great to drop somebody's blood pressure quickly, and probably the up and down roller coaster of blood pressure like that is really worse than it just consistently being high and you trying to slowly bring it down over time. So I'm really trying hard not to go that route with people. Clonidine is a central acting alpha 2 agonist, which is a lot different than the other mechanisms of these other medications that we think about. It is great for making the numbers better quickly, but then you have a rebound effect, especially if somebody is taking it regularly and they miss a dose. This is the one that can cause the big jump in blood pressure. And just a word about that, Lord, please stop sending patients to the hospital because their blood pressure's high. I don't know how many times I've heard patients go, I had to go to the emergency room because my blood pressure was at stroke level. And I always think, what does that even mean? Stroke level? Does your head explode if your systolic blood pressure gets to 180? I guess that's what people think, but no, it doesn't. Just because somebody's blood pressure is high does not mean they're in trouble. If you have evidence of end organ damage, right? If there is some abnormal thing going on with the brain or the heart or the kidneys or whatever, sure, send them to the emergency room. If the number's higher than you like, please do not make those people go to the emergency room to get their blood pressure brought down. Just treat it. Watch it come down over time. It's fine. And sometimes you have the people who are absolutely fixated on that blood pressure. They're checking it 4 times a day, and if it's even a little bit high, they're calling the office. Those are probably the people that I end up just giving up and giving them the clonidine to use as needed. One way that I do kind of like to use clonidine actually for the more difficult hypertension cases is in the patches. There's a transdermal version of clonidine where they just put a patch on and they get a set amount of it all the time. I feel safer about doing that for whatever reason, and it tends to work if you can get the dose to the right place. So I do kind of endorse that for the harder to manage hypertension people, but let's quit sending everybody to the ER, making them think they're about to have a stroke. Doxazosine is another alpha medication. It works by blocking peripheral alpha-1 receptors. So doxazosine and clonidine, both alpha medications, but they work on different receptors in different ways. Amiloride is another diuretic you can use, similar to spironolactone, so it's potassium sparing. Eplerenone is another medication in that same class you can use. Hydralazine is another option that I sometimes see cardiologists using more often. Of course, it's a nitrate, just works by causing vasodilation. And that's one that people will also get put on sometimes to have as a PRN option for when their blood pressure gets too high. So those are kind of your second, third, fourth line things to go to when the more common medicines are not working. One type of medication that has not made it into the hypertension guidelines, but that we see people get put on for heart failure is the ARNI medication, the combination of sacubitril and valsartan. Brand name is Entresto. I tell you what, that stuff lowers people's blood pressure. They're the ones that come into the office and it's 110/60, even if they're like 80 years old. That stuff works. And I have tried to use it for resistant hypertension before. I don't think the insurance coverage is probably there for that because really it's only indicated for heart failure at this point. But man, it would be nice if that made it into the blood pressure guidelines because that stuff works. And I'll tell you, that's also the one that people will get put on by their heart doctor and then come into our office saying, man, I'm so dizzy. I just feel so bad. I'm about to pass out all the time. Another thing to think about with prescribing medications is seeing if you can get multiple benefits from a single medicine. If a patient is complaining of swelling in their legs, put them on a diuretic, get rid of the swelling and lower their blood pressure. Win-win. If you see higher heart rates consistently, or if they struggle with anxiety even, maybe a beta blocker would be a good idea. Or if they have a bunch of palpitations, a beta blocker or a calcium channel blocker might be something that you reach for earlier. People who complain of cold extremities all the time, sometimes you can fix that a little bit with a calcium channel blocker, so you might get a double benefit there. Thiazide diuretics seem to have some benefit for people with kidney stones and reducing the number of kidney stones, so that might be a patient you reach for that earlier with. So those are pretty much your medication options. Sometimes you hit the nail on the head. Sometimes you write a person a medicine and they come back the next time and their blood pressure is perfect and it's not bothering them, and fantastic. They ride off into the sunset and you're good. More often, it takes some adjustment, right? So I try to prepare people for that up front. And that's probably good advice anytime you're starting a new medication or a new class of medication, is to set the expectations. Normally, I try not to use a huge dose. I try to just start with a middle of the road or low dose, depending on the patient, and just tell them, hey, take this for a couple of weeks, watch your blood pressure, see what it does. Let me know. We can adjust the dose. We can add medicine. We can change medicine. And sometimes it does take just finding the right combination and the right dosing regimen. And you can be as complicated with that as you want to. The physician that I took over for really loved to have people take a third of a tablet every 16 hours and then an eighth of a tablet on Tuesday and Saturday. And I don't like that. But sometimes you do end up getting a little creative because the patient will come in and say, my blood pressure is great in the morning, but it's not good in the afternoon. So you say, all right, well, let's split your pill in half, take half in the morning, half in the afternoon. Or take one of the medications in the morning and the other in the afternoon. And usually if you kind of work with it like that and just think about what the patient's telling you and what you're seeing, you can usually find a regimen that will work for somebody. Of course, the patient's motivation to get this under control is a big factor as well. If they're not willing to do any kind of lifestyle modification, they're not checking their blood pressure at home, and maybe they're taking the medicine now and then, it's just hard to get those people under control if they're not motivated to do it themselves. Then again, you have the other extreme who are very motivated and will harass you to death if that blood pressure is not exactly 120 over 80 or whatever they think it should be. So you just try to meet people where they are, of course, like everything else. Some other things to think about with this, I would argue that especially in elderly, frail people, it is more dangerous to drop their blood pressure too low than it is to have it run a little high. You know, if I have a choice between dropping somebody's blood pressure so much that they get dizzy and pass out and fall and break a hip, or tolerating it at 160 over 90, I'll take the higher blood pressure all day long. So with your little old frail patients, be real careful with these blood pressure medicines. Don't get too trigger happy with them, because I don't ever want to be the person that causes that kind of thing. Also remember that people who are used to having really high blood pressure may feel like crap once you lower it down to a quote unquote normal level. You know, if somebody's been used to that 160 over 90 for 20 years and now all of a sudden it's 120 over 70, they may feel like garbage, and that may actually keep them from taking the medicine and doing what you want them to do. So that's another reason to kind of go slow with the dosing. I also want to say a bit about this idea that we're supposed to treat black and white patients differently when it comes to medications. You know, there's been this idea for a long time that you're supposed to prioritize using calcium channel blockers and thiazide diuretics with black patients as opposed to starting with the ACEs and ARBs or whatever else. And I'm just going to go ahead and say that I don't like that. You know, if you read the literature, it's all this, oh, well, we found this thing where people with African ancestry are more sensitive to sodium. And, you know, I just have a hard time swallowing that. I mean, what have we ever found that has really held up over time to this idea of, oh, yeah, look, black people are different than white people? Nothing that we've ever said like that ever ends up being true. You know, we always find out, oh, look, there was racial bias in the research. Oh, hey, that's in that. So, you know, it's still in the current guidelines to do that. I just pretty much ignore that, to be honest with you. I pretty much do the same things because you're going to end up on calcium channel blockers and thiazides anyway if you're trying to get somebody's blood pressure under control. So I don't tend to even have a different strategy for people based on their skin color. Because, like, I mean, really, when has that ever been right? How long does it take us to learn this lesson? But anyway, that is still out there. And there's also all this data about disparity in how well we treat black versus white people for their hypertension. Again, just like there is in everything else. I was so fortunate to get to do some clinical rotations with a black physician. And that was one of the things that she really talked to me about. She said, you know, there's this misconception that it's harder to control black people's blood pressure. She said, but that's not right. She said, white physicians just give up on it or don't try as hard. She essentially said, that's bullshit. Keep trying, keep using the medicines, you know, keep doing what you would do for a white patient. And you know what? You can get a black patient's blood pressure under control too. Another thing to think about is you can certainly have secondary hypertension, as in there's some problem with the kidneys or the heart or the adrenal system or whatever that is causing a patient to have elevated blood pressure that you could fix. Most of the time, of course, that's not going to be the case. You know, most of the time when you go chasing that stuff, you're not going to find it. And I certainly don't recommend sending everybody with high blood pressure for evaluation before you put them on medicine. Like, just put them on medicine. Horses, not zebras. But the zebras are out there, so always be open to that if you're really having trouble controlling somebody's blood pressure, or if it just doesn't add up, right? If the clinical picture just doesn't quite make sense. Of course, most of the time that's not the case. If you have a middle-aged person with high blood pressure, they probably just have high blood pressure, and you need to find the right combination of medicine and lifestyle modification that's going to get it back under control. But do keep that in the back of your mind. If you have a very young person who comes in and has crazy high blood pressure, maybe you would think about looking more into that. Maybe you do want an echo. Maybe you do want a renal ultrasound to make sure the blood flow to their kidneys is all right. Maybe you do want to look for some crazy pheochromocytoma or something like that. Remember to always look at the medicine list. Is there anything that we're doing to the patient that's causing this? If you have a patient on a stimulant like Adderall and their blood pressure is running high, you either need to stop that Adderall or get them on medicine to get that blood pressure under control, because very likely that's contributing to it. Some other medications that they might be on to think about: NSAIDs, oral contraceptive pills, antidepressants that affect norepinephrine, acetaminophen if they use it regularly, steroids, all these herbal things that people take. Any of those things can potentially increase a person's blood pressure. Another huge thing to think about with secondary hypertension is sleep apnea. I'm trying to ask about that more and more because we probably have a lot of undiagnosed sleep apnea out there. I think people don't immediately associate that with cardiovascular risk, but of course that's the main problem with it, right? Yes, it's nice to sleep well, and a lot of people will notice better sleep quality and energy level once their sleep apnea is treated. But the main reason we care about it is because it makes the heart work harder through the night if you can't breathe, and it turns into a cardiovascular issue over time. So if you ever suspect sleep apnea for any reason, or if you're having trouble controlling a person's blood pressure, I want to send them for a sleep study. Make sure they don't have that. Thyroid is another thing that can cause secondary hypertension, right? If your thyroid is cranking out too much hormone, obviously that's going to make your blood pressure and heart rate go up. And I think the final thing is, remember that you can reach out for help. If you have a patient that it's very, very hard to control their blood pressure, or if you suspect they really do have some kind of heart issue, send them to cardiology. That's part of their job too. They can get a full evaluation and make sure that there's not some secondary cause that you've overlooked. Sometimes I think they're more willing to use more expensive medicines or different combinations of medicine that maybe we would shy away from in primary care. And also, I believe in the psychological effect of them just knowing that they're having to go see a heart doctor. It's one thing if Jody gently suggests that you might want to consider medicine. It's another thing when a cardiologist tells you that you're going to fall over dead if you don't take these 7 medications right now. So don't be afraid to pull that ripcord if you need to. It's totally legit to send somebody to cardiology to help with hypertension management. So yeah, I think that about covers it. That's pretty much how I think about managing hypertension. I will put links in the show notes to a couple of different guidelines on hypertension management, as well as an article from 2023 about racial and ethnic disparities in hypertension, which is always an interesting subject to me. If you have any thoughts, if you have anything to add, if you noticed anything that I said that's wrong, get in touch. Let me know about it. Thanks for listening. I hope this is helpful, and I'll talk to you next time. All right, that does it for this episode of Knowledgeable Provider. I'm your host, Jody Marks. Thank you so much for listening. Please be sure to like, subscribe, or follow on your preferred listening platform. Give us a nice 5-star rating and leave a nice review. If you'd like to help support the show, you can do that at patreon.com/knowledgeableprovider. And as always, stay safe, take care of yourself, and take care of your patients in that order.